Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 267 of our pharmacotherapy series, which majors in tuberculosis. This video is a continuation of the case of patient H.T.G discussed in part 266 of this pharmacotherapy series on TB. H.T.G's HIV test is negative. How should treatment be initiated in H.T.G, pending the results of sputum culture and susceptibility testing? Can he transmit Mycobacterium tuberculosis to others during treatment? There are 4 basic regimens recommended for the treatment of adult patients with active TB caused by organisms that are known or presumed to be drug susceptible. Because H.T.G has not been treated previously for TB, he should be started on isoniazid, rifampin, pyrazinamide, and ethambutol. However, he has been in close contact with persons with symptoms resembling TB who are from an area, that is Mexico, with a high prevalence of drug-resistant TB. Therefore, H.T.G must be closely monitored for resolution of symptoms, results of repeated sputum smears, and culture and susceptibility results, regardless of the initial treatment regimen. Previous guidelines recommended the addition of ethambutol only if the local prevalence of isoniazid-resistant Mycobacterium tuberculosis is at least 4%. In the United States, 9.3% of Mycobacterium tuberculosis isolates recovered from patients with no previous history of TB were resistant to isoniazid in 2014. The prevalence of isoniazid resistance was higher in foreign-born persons, 10.2%, compared with US-born persons, 7.5%. In patients with a history of previous of TB, 18.9% of strains were resistant to isoniazid in 2014, with 24.7% resistance in foreign-born persons versus 4.4% resistance in US-born persons. Because of the relatively high likelihood of TB caused by isoniazid-resistant organisms, 4 drugs are necessary in the initial 8-week treatment phase. The initial 4-drug regimen may be administered daily throughout the 8-week period, regimen 1, daily for the first 2 weeks and then twice weekly for 6 weeks, regimen 2, or thrice weekly throughout regimen 3. Based on clinical experience, administration of drugs for 5 days per week is considered to be equivalent to 7 days per week administration, and either regimen 1 or 2 may be considered daily. However, 5-day-a-week administration should always be given by DOT. H.T.G should be started on isoniazid 300 mg daily, rifampin 600 mg daily, pyrazinamide 1500 mg daily, and ethambutol 1200 mg daily. He should also receive pyridoxine 25 mg per day to minimize the risk for development of isoniazid-induced peripheral neuropathy. Fixed-dose combinations of drugs have been advocated to improve adherence to the prescribed regimen, especially during the critical initial treatment phase. There are two fixed-dose combination preparations available in the United States, Rifam-8, which contains isoniazid 150 mg and rifampin 300 mg per capsule, and Rifata, which contains isoniazid 50 mg, rifampin 120 mg, and pyrazinamide 300 mg per tablet. These formulations are a means of minimizing inadvertent monotherapy, especially when DOT is not possible, and they may decrease the risk of acquired drug resistance while reducing the number of capsules or tablets that must be ingested each day. Safety and efficacy of a 4-drug fixed-dose combination regimen was compared with each drug administered separately in patients with pulmonary TB. The combination tablet contained isoniazid 75 mg, rifampin 150 mg, pyrazinamide 400 mg, and ethambutol 275 mg, and 2 to 5 tablets were ingested per day based on body weight. The number of patients who were culture negative at 18 and 24 months was similar between the treatment groups, in addition to the number of treatment failures, relapses, and death. The 4-drug fixed-dose combination was non-inferior to each drug administered separately. It should be noted that there was no difference in outcomes based on HIV status, but less than 7% of the study subjects were HIV positive. The high risk of transmission of Mycobacterium tuberculosis to other persons mandates that hospitalized persons with suspected or confirmed infectious TB be placed in respiratory isolation until they are determined not to have TB, they are discharged from the hospital, or they are confirmed to be non-infectious. Based on H.T.G's subjective and objective findings, he should be placed in respiratory isolation. H.T.G's symptoms should improve within the first 4 weeks. He would be considered to be non-infectious when he is receiving effective drug therapy, is improving clinically, and has had negative results for 3 consecutive sputum AFB smears collected on different days. Patients who have responded clinically may be discharged to home despite positive smears if their household contacts have already been exposed and these contacts are not at increased risk of TB, e.g., infants, HIV-positive and immunosuppressed persons. In addition, patients discharged to home with positive smears must agree not to have contact with other susceptible persons. Let's now briefly talk about fluoroquinolones as initial therapy. Interest in fluoroquinolones for the treatment of TB dates back more than 30 years, with a report describing the use of ofloxacin in 19 patients with chronic, drug-resistant TB disease. Several fluoroquinolones possess in vitro activity against Mycobacterium tuberculosis, but moxifloxacin and gatafloxacin are 4 to 8-fold more potent than levofloxacin. Moxifloxacin was compared with ethambutol in the first 2 months of treatment in adults with smear-positive pulmonary TB. Patients were randomly assigned to receive moxifloxacin 400 mg daily or ethambutol based on body weight, and all patients received isoniazid, rifampin, and pyrazinamide. Patients receiving moxifloxacin were more likely to have negative sputum cultures at 4 weeks and 6 weeks, but the 2-month conversion rates were equal in each group. In another study, sputum culture conversion at 8 weeks was significantly greater in patients treated with moxifloxacin when compared with ethambutol, 80% versus 63%. Culture conversion rates were also significantly higher in the moxifloxacin group at weeks 1, 2, 3, and 4, and the median time to consistently negative cultures was 35.0 days in the moxifloxacin group and 48.5 days in the ethambutol group. Moxifloxacin has been compared with isoniazid during the intensive phase of treatment of pulmonary TB. Patients were randomly assigned to receive moxifloxacin 400 mg or isoniazid 300 mg daily, and all patients received rifampin, pyrazinamide, and ethambutol. After 8 weeks, negative sputum cultures were observed in 60.4% of the patients in the moxifloxacin group and 54.9% of patients in the isoniazid group, but this difference was not statistically significant. Despite the reported efficacy of fluoroquinolones in the treatment of TB, clinicians must be cognizant of the potential development of resistance to this important drug class. Fluoroquinolone resistance in Mycobacterium tuberculosis has been described, occurring more frequently in multidrug-resistant isolates. Fluoroquinolones are the most commonly prescribed antibiotic class in the United States, and outpatient use for infections other than TB could be a potential risk factor for TB resistance in a patient who becomes infected with Mycobacterium tuberculosis. In a study evaluating risk factors for fluoroquinolone-resistant Mycobacterium tuberculosis, investigators identified newly diagnosed patients with culture-confirmed TB in a Medicaid population. Of the 640 patients evaluated, 116, that is 18%, patients had fluoroquinolone exposure within the 12 months before diagnosis with TB, and 16, that is 2.5%, patients were infected with Mycobacterium tuberculosis strains that were fluoroquinolone resistant. The study found that receipt of a fluoroquinolone for more than 10 days, occurring more than 60 days before diagnosis of TB, was associated with the highest risk for fluoroquinolone resistance. Therefore, judicious use of fluoroquinolones, especially in patients at risk for TB infection, is mandatory to maintain the utility of fluoroquinolones in the treatment of TB. We will now briefly discuss susceptibility testing. Drug susceptibility testing is essential to ensure proper treatment of patients with active disease and should be performed on the initial isolate of Mycobacterium tuberculosis from all patients. Susceptibility testing should also be performed if cultures remain positive after 3 months of therapy or if negative cultures become positive after a period of time. Traditionally, susceptibility testing is performed by growing the organism on solid or in liquid media containing the drug. The agar proportion method allows for quantitation of the proportion of organisms that are resistant to a given drug, which is expressed as a percentage of the total organism population tested. A drug will not be useful for therapy if 1% or more of the total population are resistant to the drug. Unfortunately, susceptibility results may not be available for several weeks because of the slow growth of the organism and the need to isolate the pathogen before susceptibility testing can be performed. To expedite susceptibility reporting, molecular drug resistance tests have been developed to detect mutations in the chromosomal sequence encoding for resistance to a specific drug directly on clinical specimens without the need for growth on culture. For example, mutations in the RPOB gene block the activity of rifampin by preventing the drug from binding to RNA polymerase. Approximately 95% of rifampin-resistant Mycobacterium tuberculosis carry this mutation, and treatment failures have been associated with the presence of RPOB mutations. The molecular drug resistance test amplifies the target genetic sequence using polymerase chain reaction, and a second assay, such as DNA sequencing and hybridization assays, is used to determine whether the sequence contains a mutation associated with drug resistance. If a mutation is detected, the organism is considered to be drug resistant, but the organism is presumed to be drug susceptible if a mutation is not detected. Molecular tests can reliably detect the presence of known mutations within 1 to 2 days, which may result in earlier initiation of effective therapy, shorter durations of infectivity, and reduced spread of TB. However, these molecular drug resistance tests can only detect a specific set of known mutations and cannot identify novel mutations conferring resistance. Therefore, traditional susceptibility testing continues to play an important role in confirming results of molecular testing. Kits for detecting mutations associated with rifampin resistance include genotype MTBDR+ and INNOLIP-ARIF-TB. Compared with culture-based drug resistance tests, the sensitivity and specificity of the MTBDR+ line probe assay were 98% and 99%, respectively, for detecting rifampin resistance in isolates or directly from clinical specimens. The sensitivity of the INNOLIP-ARIF-TB assay ranged from 80% to 100% and the specificity was 100% for detecting rifampin resistance directly from clinical specimens. Molecular beacons are hybridization probes that use fluorescent-labeled, hairpin-shaped DNA probes with a fluorophore adjacent to a molecule that prevents fluorescence. Using a real-time polymerase chain reaction assay, fluorescence occurs if the amplified PCR products have the wild-type gene sequence, but fluorescence is not detected if mutations are present in the target sequence. These tests have high sensitivity 96% to 97% and specificity 99% to 100% for rifampin resistance in clinical specimens. Molecular drug resistance tests for other antitubercular drugs are not fully developed compared with tests for rifampin resistance. For detecting mutations associated with isoniazid resistance, the specificity of the MTBDR+ assay was 100%, but the sensitivity ranged from 57% to 100%, pooled sensitivity 85%. However, rifampin resistance is a reliable surrogate for MDR-TB in the United States because isolated rifampin resistance is uncommon. The Expert MTB-RIF assay is an automated molecular-based test that uses nested real-time polymerase chain reaction, allowing for simultaneous detection of Mycobacterium tuberculosis and rifampin resistance. The test is approved for diagnostic testing of raw sputum samples, and results are available within 2 hours. Sensitivity is 95% to 98.2% in AFB culture or smear-positive specimens, but performance is correlated with bacterial load because sensitivity is only 55% to 72.5% in smear-negative specimens. Sensitivity is also lower in patients with HIV infection. Specificity was 94% to 99.2% in patients with negative cultures. The Expert MTB-RIF test also correctly identified 98.1% of patients with rifampin-susceptible bacilli and 97.6% of patients with rifampin-resistant bacilli. The next question reads, is H.T.G a risk to the community and does anyone need to know? Yes, each case of active TB disease must be reported to the local, state, or both public health departments. This not only results in optimal therapy by monitoring adherence to therapy, but it also ensures that contact and source case investigations will be performed. All individuals who have been in close contact to H.T.G should be evaluated for latent TB infection or active disease. Considering their close contact to H.T.G and his coworkers, his family members should be evaluated. Reporting of cases also permits record keeping and surveillance to determine whether public health TB control efforts are achieving the goal of preventing the spread of TB. The next question reads, 4 weeks later, H.T.G's initial sputum cultures were reported to be positive for Mycobacterium tuberculosis. Drug susceptibility testing to isoniazid and rifampin revealed susceptibility to both agents. What drug regimen should be used for continued treatment of H.T.G? How long should treatment be continued? Successful treatment of uncomplicated TB can be achieved in 6 months, that is 26 weeks, if isoniazid, rifampin, pyrazinamide, and ethambutol are used for the first 2 months, that is 8 weeks, and if patient adherence to the regimen and the organism's susceptibility can be assured. Therefore, after 8 weeks of DOT with isoniazid, rifampin, pyrazinamide, and ethambutol, H.T.G's regimen may be streamlined to isoniazid and rifampin daily, 5 days or 7 days per week, or 2 to 3 times per week under continued DOT for an additional 18 weeks. Because H.T.G is HIV negative and cavitary lesions were not present on his chest radiograph, he may also be a candidate for once-weekly administration of isoniazid and rifapentine, as long as his sputum AFB smear is negative after completing the initial 8 weeks of therapy. The effectiveness of a primarily twice-weekly treatment regimen has been demonstrated in both pulmonary and extrapulmonary TB. The regimen consisted of isoniazid 300 mg, rifampin 600 mg, pyrazinamide 1.5 to 2.5 grams, and streptomycin 750 to 1000 mg intramuscularly daily for 2 weeks, followed by the same drugs twice weekly for an additional 6 weeks. The regimen was then reduced to isoniazid and rifampin twice weekly for the remaining 16 weeks, that is 4 months. At 3 months, 75% of patients had negative sputum cultures, and all patients were culture negative at 20 weeks. Relapse occurred in 2 patients and only minor adverse effects were reported. Another important feature is that this regimen is highly cost-effective. Among the 6 and 9-month regimens, it is the second lowest in cost, primarily because of the least number of patient healthcare worker encounters, that is 62 directly observed doses. If pyrazinamide cannot be included in the initial regimen, therapy should be initiated with isoniazid, rifampin, and ethambutol for the first 8 weeks. Therapy should be continued with isoniazid and rifampin for 31 weeks given either daily or twice weekly. If drugs other than isoniazid and rifampin are used in the initial phase, treatment must be continued for 18 to 24 months. Twice-weekly administration of isoniazid 900 mg and rifampin 600 mg is recommended for H.T.G because this approach requires fewer doses and should result in substantial cost savings. In addition, the relapse rates for the twice- and thrice-weekly isoniazid and rifampin continuation regimens are significantly lower than the once-weekly regimen of isoniazid and rifapentine 600 mg. 5 characteristics were associated with increased relapse risk in the isoniazid and rifapentine group: sputum culture positive at 2 months, cavitation on chest radiograph, underweight, bilateral pulmonary involvement, non-Hispanic Caucasian race. A potential explanation for these results is the high protein binding of rifapentine, 98%. A study evaluated the safety and tolerability of rifapentine 600, 900, and 1200 mg once weekly with isoniazid 15 mg per kilogram in 150 HIV-negative patients. A trend toward more adverse events was observed in the 1200 mg treatment arm, with a p-value equal to 0.051, but the 900 mg dose was well tolerated. However, relapse rates for the higher dose weekly rifapentine regimens with isoniazid are unknown. A subsequent study demonstrated that low plasma concentrations of isoniazid were associated with failure or relapse with once-weekly isoniazid and rifapentine. 2 patients who relapsed with Mycobacterium tuberculosis monoresistant to rifamycin had very low isoniazid concentrations. Rapid acetylation status was a risk factor in those patients who failed or relapsed. Rifamycin pharmacokinetics did not influence patient outcomes, however. Treatment with isoniazid and rifampin should be continued for a minimum total duration of 26 weeks. A full course of therapy can be more accurately determined by the total number of doses ingested, not solely by the duration of therapy. Thus, 26 weeks is the minimum duration of treatment and accurately indicates the amount of time the drugs are given only if there are no interruptions in drug administration. Pyridoxine 10 to 25 mg per day should be continued throughout the treatment period. If H.T.G is symptomatic, or smear or culture is positive after 3 months of therapy, he should be re-evaluated for possible non-adherence with his therapy, malabsorption of the drugs, or infection with drug-resistant organisms. Evaluation should include a second culture and a second susceptibility test, consideration of DOT if not already instituted, and consultation with experts in the treatment of TB. The next question reads, H.T.G is concerned about the long duration required for treatment of his infection. He asks whether there is any way to shorten the length of treatment. Are there any effective treatment regimens that may be administered for less than 26 weeks? Treatment of active TB for 26 weeks is a challenge to ensure patients adhere to the prescribed regimen for the total duration of therapy. Shorter course treatment regimens, if efficacious, could be helpful in improving adherence rates, decreasing treatment costs, and reducing adverse events. 3 published studies evaluated the treatment of drug-susceptible TB for a total duration of 4 months using modified regimens that included a fluoroquinolone, moxifloxacin or gatafloxacin. The control regimen was the same in each study and consisted of 8 weeks of isoniazid, rifampin, pyrazinamide, and ethambutol followed by isoniazid and rifampin for 18 weeks. In all 3 studies, unfavorable outcomes and culture-confirmed relapse or recurrence were more common in patients receiving the short-course regimens, therefore, non-inferiority was not demonstrated for any of the 4-month regimens. Based on these studies, H.T.G should receive 26 weeks of therapy, and every effort should be made to ensure adherence to the treatment regimen. The next question reads, what is directly observed therapy, and why is it important for H.T.G to be treated by directly observed therapy? Directly observed therapy, abbreviated as DOT, is the practice of a healthcare provider or other responsible person observing as the patient ingests and swallows the TB medications. DOT is the preferred core management strategy for all patients with TB. The purpose of DOT is to ensure adherence to TB therapy. DOT not only ensures completion of therapy, but it may also reduce the risk of developing drug resistance. By improving these 2 factors, it also reduces the risk of transmission of TB to the community. DOT can be administered with daily or twice and thrice weekly regimens. It can be administered to patients in the office or clinic setting, or it can be given at the patient's home, school, or work. Often, enablers or incentives, such as food, clothing, or transportation, are used to improve adherence to DOT. A comprehensive review of DOT-related articles found that the completion rate of TB therapy exceeds 90% when DOT is used along with enablers. A study found that culture-positive patients treated for active pulmonary TB with DOT had significantly higher cure rates, 97.8% versus 88.6%. With a p-value less than 0.002, and lower TB-related mortality, 0% versus 5.5%. With a p-value equal to 0.002, compared with patients treated using self-administered therapy. Although DOT is recommended for all patients, public health departments may not be able to provide DOT for all patients because of the associated costs. The initial cost of DOT is greater than self-administered therapy. However, when costs of relapse and failure are included in a cost-effectiveness analysis, DOT is significantly less expensive than self-administered therapy. When drug resistance develops, in those instances in which DOT is not used, the cost of salvage therapy increases to $180,000 per patient. It is, therefore, widely accepted that patients with TB should receive DOT. The next question reads, why are multiple drugs recommended for treatment of active TB disease? What is the role of each drug in the treatment of active TB? The key to treating active TB disease is multiple drug therapy for a period sufficient to kill the organisms and to prevent development of resistant strains of Mycobacterium tuberculosis. Most cavitary lesions contain a concentration of 109 to 1012 organisms, and the frequency of mutations that confer resistance to a single drug is approximately 10 to 6 for isoniazid and streptomycin, 10 to 8 for rifampin, and 10 to 5 for ethambutol. Considering the inoculum of organisms involved, patients with active TB disease likely harbor organisms with random mutations that confer drug resistance to a given drug. If a single drug is given, it would reduce the number of drug-susceptible organisms but allow the drug-resistant organisms to replicate. By using multiple drug therapy, the likelihood of encountering organisms with mutations to multiple drugs is reduced. For example, the frequency of concurrent mutations to isoniazid and rifampin would be 10 to 14, 10 to 6 for isoniazid and 10 to 8 for rifampin, making simultaneous resistance to both drugs an unlikely event in an untreated patient. Therefore, monotherapy should never be used in the treatment of active TB disease. Multiple drug therapy also serves to sterilize the sputum and lesions as quickly as possible. The drugs available for the treatment of TB vary in their ability to accomplish this task. Drugs effective against tubercle bacilli can be divided into first-line and second-line agents. The foundation of treatment should be with first-line agents, such as isoniazid, rifampin, pyrazinamide, and ethambutol. Of the various agents, isoniazid has the most bactericidal activity versus rapidly multiplying Mycobacterium tuberculosis during the initial phase of therapy, early bactericidal activity, followed by ethambutol, rifampin, and streptomycin. Drugs that have potent early bactericidal activity more rapidly decrease the infectiousness of the patient and reduce the likelihood of developing resistance. Pyrazinamide has weak early bactericidal activity during the first 2 weeks of therapy and is less effective at preventing emergence of drug resistance than isoniazid, rifampin, and ethambutol. Therefore, pyrazinamide should not be combined with only one other agent when treating active TB disease. Rifampin also has activity against intracellular organisms that are usually dormant but undergo periods of active growth. This ability to penetrate and destroy the persistent intracellular organisms makes rifampin extremely valuable in short-course chemotherapy regimens. Pyrazinamide is most effective against tubercle bacilli in the acidic environment within the macrophage or areas of tissue necrosis. In addition, it is most effective in sterilizing lesions when used in the first 2 months of treatment, but it does not offer substantial sterilizing activity after 2 months. Pyrazinamide should be considered an essential component of short-course regimens. Ethambutol is bacteriostatic at low doses, but bactericidal at higher doses. It is moderately effective against the fast-growing bacilli. It has little sterilizing activity and is primarily used to prevent the emergence of drug-resistant organisms. Streptomycin is bactericidal against rapidly multiplying extracellular organisms and is effective when given daily for 2 months followed by twice or thrice weekly administration thereafter. In the past, streptomycin was administered by intramuscular injection, but these intramuscular injections were painful. Therefore, although it is not labeled for intravenous use, streptomycin may be given in 50 to 100 ml of 5% dextrose in water or normal saline and infused for 30 to 60 minutes. Streptomycin can cause ototoxicity and nephrotoxicity, as with other aminoglycosides. Other drugs used in the treatment of TB: bed-aquiline, capreomycin, amikacin, cycloserine, ethionamide, p-aminosalicylic acid, are usually reserved for cases involving drug-resistant organisms, treatment failures, drug toxicity, or patient intolerance to the other agents. The next question reads, what subjective and objective findings should be followed to ensure therapeutic efficacy and to minimize drug toxicity? Should H.T.G be followed closely after completion of his treatment regimen? H.T.G should be questioned about the occurrence of adverse reactions associated with his therapy. Specifically, he should be asked about anorexia, nausea, vomiting, or abdominal pain, which may be an indication of possible hepatitis secondary to isoniazid, rifampin, or pyrazinamide. He should be questioned about numbness and tingling in his extremities. However, isoniazid-induced peripheral neuropathy should not be a problem in H.T.G because he is also taking pyridoxine, which should prevent this adverse effect. H.T.G also should be examined for, and questioned about petechiae or bruises, because thrombocytopenia occurs occasionally with intermittent rifampin therapy. This effect purportedly occurs more frequently with intermittent rifampin therapy, but it is rare at the currently recommended intermittent rifampin dose of 10 mg per kilogram per day, that is approximately 600 mg. In a study comparing 6 versus 9-month anti-tuberculosis therapies of mostly isoniazid and rifampin, the incidence of side effects was similar between the two groups. Adverse effects occurred in 7.7% of patients in the 6-month arm compared with 6.4% in the 9-month arm, a difference that was not statistically significant. Hepatic abnormalities occurred in 1.6% of patients in the 6-month regimen, a non-significant difference from patients in the 9-month regimens, 1.2%. Hematologic events were rare at 0.2% and 0.0% in the 6 and 9-month groups, respectively. Other reported effects, gastrointestinal problems, rash, and arthralgias were minor and infrequent in both regimens. Let's briefly talk about objective signs. A pretreatment complete blood count, platelet count, blood urea nitrogen, hepatic enzymes, that is serum aminotransferases, bilirubin, and serum uric acid should be evaluated. Baseline visual examination should also be considered for patients receiving ethambutol. These tests are performed to detect any abnormality that may complicate or necessitate modification of the prescribed regimen. These tests should be repeated if the patient experiences any evidence of drug toxicity or has abnormalities at baseline. H.T.G is 35 years of age and at increased risk for development of drug-induced hepatotoxicity. Isoniazid can cause asymptomatic increases in serum transaminases as well as overt hepatitis. Pyrazinamide has also been associated with hepatotoxicity, but the incidence is less common at doses of 25 mg per kilogram per day or less. Transient asymptomatic hyperbilirubinemia and cholestatic hepatitis can occur in patients receiving rifampin. Therefore, it is important that H.T.G be educated about possible symptoms of hepatotoxicity, primarily nausea, vomiting, abdominal pain, anorexia, and jaundice. Monthly serum liver function tests are no longer recommended because they are costly, and transient, asymptomatic elevations in liver function tests may occur, which could result in unnecessary discontinuation of optimal therapy. The CDC recommends that medical personnel question patients about symptoms once monthly. Sputum cultures and smears for AFB should be ordered every 2 to 4 weeks initially and then monthly after the sputum cultures become negative. With appropriate therapy, sputum cultures should become negative in more than 85% of patients after 2 months. Radiologic examination, that is chest radiographs, is not as important as sputum examination, but it may be useful at the completion of therapy to serve as a comparison for any future films. Patients who are culture positive at 2 months need to be carefully re-examined. Drug susceptibility testing should be performed to rule out acquired drug resistance, and special attention should be given to drug adherence, i.e., DOT should be used. If drug resistance is demonstrated, the regimen should be modified as needed. Sputum cultures should also be obtained monthly until negativity is achieved. As was the case for H.T.G, weight loss and nutritional depletion are common in patients with active TB disease. In a large TB treatment study, 7.1% of patients experienced relapse, with relapse greatest in patients who were underweight at diagnosis or with a body mass index less than 18.5 kg per meter squared. In those patients underweight at diagnosis, defined as equal to or greater than 10% below ideal body weight, weight gain of 5% or less between diagnosis and completion of 2 months of therapy was independently associated with relapse. In addition, the relapse rate was 50.5% in underweight patients with a cavitary lesion on chest radiograph, positive sputum cultures after 2 months of therapy, and a 5% or less weight gain in the first 2 months of therapy. Therefore, it may be prudent to monitor H.T.G's body weight during the initial 2 months of therapy, and he may need to receive more intensive therapy or a longer duration of therapy. Routine follow-up usually is not required after the successful completion of chemotherapy with isoniazid and rifampin. It may be prudent, however, to re-examine the patient 6 months after completion of therapy or at the first sign of any symptoms suggestive of active TB. This is especially important in patients who were slow to respond to therapy or who have significant radiologic findings at completion of therapy. These recommendations are only for those patients with organisms fully susceptible to the medications being used. Patients who are culture negative but have radiographic abnormalities consistent with TB should have an induced sputum or bronchoscopy performed to establish a microbiologic diagnosis and monitored radiographically. Patients with extrapulmonary TB should be evaluated according to the site of involvement. The next question reads, if H.T.G does not respond to his currently prescribed treatment regimen, should one more drug be added to his regimen? No, adding a single drug to a failing regimen is the most common and devastating prescribing error in TB therapy. This practice is essentially monotherapy because the assumption is that the organisms are resistant to the medications currently being used. Resistance to the new drug will eventually develop, further reducing the patient's chance of cure. At least 2, and preferably 3, new drugs to which susceptibility can be inferred should be added to lessen the probability of further acquired drug resistance. Empiric retreatment regimens may include a fluoroquinolone, beta-aquiline, an injectable agent, e.g., streptomycin, amikacin, or capreomycin, and an additional oral agent, e.g., p-aminosalicylic acid, cycloserine, or ethionamide. New drug susceptibility testing should be performed and treatment adjusted accordingly. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 268.